Good afternoon, everyone, and welcome to the Lusaka Apex Medical University Virtual Clinical Educational Grand Round. I'm your host, Ms. Shinodo, here as part of Corporate Communications at LAMU. Today's topic is Placenta Previa, which is being presented by the Faculty of Nursing. A quick reminder, the purpose of these grand rounds is to provide a platform for our LAMU students to present the patient cases they encounter during the ward rounds. So, by virtue of that, these are presentations for our students, by our students. Through these, they cultivate various skills such as long case presentation, critical thinking, public speaking, and self-presentation on a platform, whether physical or virtual. I would like to acknowledge the presence of our professorial team. We have Professor Njelesani, Professor Lambart, Professor Mudenda, Professor Mwaba, Professor Mulenga, Professor Mwansa, and Professor M Emaus. As I said, today's team is from Faculty of Nursing. A quick description: placenta previa is a condition that occurs during pregnancy where the placenta is, instead of being at the top, it is at various degrees displaced within the uterus. I would like to invite one of our moderators, Mr.M.Kabangasheshe, to briefly introduce the topic and begin the presentation. Kabangasheshe, the floor is yours.
Thank you very much, Dr. Like you said, there's a topic or a case study of placenta previa. So this is a case study that was conducted by our Diploma Nursing Students from the University Teaching Hospital here in Lusaka. And the team comprises of Tricia Mulenga, Mahongo Chitoka, and J Mudenda. These are our third-year students who are our incoming senior students for the Faculty of Nursing and Midwifery Diploma Department. I would like to pass a vote of thanks to the dean of our faculty, that is Mrs. Mwansa, the HOD, Mrs. Banda, that is HOD under Diploma, the HOD under Degree, that is and HOD under Midwifery, that is Mr. M. Then within our audience here, I have Mrs.Kasonde, who is part of our Moderators. That was very instrumental in guiding our students throughout the case study. I would like also to pass a lot of thanks to the faculty members, Mr. Silame from the clinical department, that is Mr. Sanga also for the guidance that was given by the students, Mrs. Gara from the midwifery department for the guidance as well. At this stage, I would like to call upon the first presenter from the team. This is none other than Tricia Mulenga to present the first part of our case. Tricia, the floor is yours.
Thank you very much, sir. Before I introduce myself, our protocols are highly observed to our moderators and their staff. So my name is Tricia Mulenga, as mentioned earlier on, from July 2021, third-year student, pursuing Diploma in Nursing and Midwifery. So we're here to do a presentation on a patient who had placenta previa. So allow me to run you through the introduction. So this is a case study which was carried out from the University Teaching Hospital, Ward BO3, which is an obstetrics ward. The aim of this case study is to come up with a comprehensive health history and diagnosis of our patient that will guide us in the management of problems she presented with during hospitalization until discharge. This case study was conducted on a female patient aged 31, 4 minutes during our obstetrics and gynecological clinical allocation. This case study was on EN, a gravida 4 periphery at 36 weeks of gestation, who came in as a referral from Sikanze Barracks Police Hospital. The patient started experiencing venous vaginal bleeding on the 28th of February 2023 around 13 hours and went to Sikanza Barracks Police Hospital for a checkup. While she was referred to the University Teaching Hospital with a provisional diagnosis of puerperal antepartum hemorrhage secondary to placenta previa for further investigations in infantry. So our ethical consideration as we went to NISAT, or rather should they say, as we went to carry on with the case study was that we greeted our patient with respect, introduced ourselves, and explained what the case study was all about, so that she could understand the importance as well as obtain cooperation and adequate information, ensuring that we maintain confidentiality. And this history was obtained from the patient herself. So now I'm going to look at the demographic data of this patient. Her name was EN, sex, female, age 31 years, date of birth, 3rd of April 1992, belonged by tribe, religion, Christianity, specifically United Church of Zambia. Occupation, she was an accountant, and the informant was a patient herself. Marital status of this patient was she was married. The next of kin was KM, who appeared to be the husband. The residential address was Chilenge, source of healthcare, Sikanza Barracks Police Hospital. HIV status was non-reactive, Ward BO3. Date of admission, 28th of February 2023. Date of interview, 7th of March 2023. Time of interview was 10 hours, and her stay in the hospital was 7 days post admission. So our patient EN came in with chief complaints upon admission. So EN was brought into the hospital on the 28th of February 2023, around 13:56 hours, with complaints of painless vaginal bleeding. She was being reviewed by the doctors on duty in BO3 while she was diagnosed with incomplete placenta previa after running several investigations. Her past health history is as follows. The patient had no history of any surgery or history of hypertension, epilepsy, tuberculosis, asthma, diabetes mellitus, and sickle cell disease. Her family health history, EN had a positive history of pulmonary tuberculosis and hypertension in the family. EN had no positive history of epilepsy, asthma, diabetes mellitus, and sickle cell disease. Her past obstetrics history, EN was a Bermuda-4 para-3 at 36 weeks of gestation, and the patient had previously given birth to a stillborn at 30 weeks of gestation, and it was a macerated stillborn and had given birth to 2 viable infants in the past via spontaneous vaginal delivery. Her present obstetrics history, the last menstrual cycle was on the 15th of June 2022, and the expected date of delivery was on the 22nd of March 2023. EN has not been bleeding for the past few days after admission, but on the 3rd of March 2023, she experienced painless vaginal bleeding in which she used 3 sanitary pads, but the bleeding reduced later on in the day, and the bleeding ceased following day in the morning. So now we're going to look at how she was managed while she was still on the ward, and we're going to talk about the drug history, if she took any prescribed or self drugs. So EN did not take any self-prescribed medication at home, and she has no drug allergies, but she was being managed on ferrous sulfate 200 milligrams TDS per hour So they were actually giving her ferrous sulfate in order to prevent iron deficiency anemia. So actually iron helps in the production of healthy red blood cells that are actually happening to be oxygen carrying capacity in the body. And then she was also being managed on folic acid, 5 milligrams or so they were giving folic acid in order to prevent folate deficiency anemia. And thirdly, she was being managed on dexamethasone, 4 milligrams as a start dose. So for dexamethasone, normally they give because they are trying to improve on the maturation of the fetal lungs, because this baby is prone to be born as a preteen. And at this point of time, I'm going to hand over the presentation to my friend, Mahongo Chitoka.
Thank you very much. My name is Mahongo Chitoka. I'm going to start from where my colleague has ended. So I'm presenting on physical examination. So on physical examination, the latest vitals of these patients, they were blood pressure, 100/63 millimeter of mercury. Then the pulse was 106 beats per minute. Then the respiration, 20 beats per minute. Then the temperature was 36.6 degrees Celsius. So we did specific examination where a head to toe physical examination was conducted on EN, and the findings were as follows. So on the head, it was symmetrical, no scars. Then the hair was well distributed and healthy, and it was also clean. Then the eyes were symmetrical. EN had some mild pallor, but no signs of infection. And on the nose, there was no secretion, no polyps, and no nasal flaring. Then on the mouth, mucous membranes showed signs of pallor. Then on the ears, they were symmetrical. There was no discharge and no swollen lymph nodes behind the ears. Then on the neck, there was symmetrical. No inflamed cervical lymph nodes. Then we also checked the upper limb and the lower limb of the patients. So on the upper limbs, they were symmetrical, no signs of any congenital abnormalities, and EN had bilateral lower limb edema. On abdominal palpation, on inspection, the signs of pregnancy were noted during inspection, such as straight gravidaria and linea nigra. And the size of the abdomen was checked to compare with the gestation age. On auscultation, fetal heart rate was 120 beats per minute, and the fetal movement was felt by the mother. Then on the palpation, abdominal palpation was done, and height of fundus was at 36 weeks. Then the fetal parts were felt. Then the lie of the fetus was longitudinal, and the presentation was cephalic. Then on the investigation was also done. So the results were, full blood count result was hemoglobin of 8.0 per deciliter. Then secondly, we did grouping and cross-matching plus rhesus factor, which was B+. Then 3, we did clotting time, which was 5 minutes. Then on urinalysis, we also did the protein was present, which was 3+. Then we also did the scan stroke ultrasound, The results was single live fetus encephalic presentation with placenta previa type 3. So the summary of findings. Several investigations were done on the patient, such as full blood counts, which showed the patients had mild anemia with the hemoglobin level of 8.0 per deciliter. Then urinalysis was done, which revealed proteinuria, which was 3+ with no elevated blood pressure. Bilateral lower edema was present. Then on the ultrasound scan was also done, which reviewed as a single live fetus encephalic presentation with a lower lying placenta, which was type 3 or incomplete. Then therefore, the diagnosis was made as the antepartum hemorrhage secondary to placenta previa. So the diagrams which are here, it's just showing the different steps of placenta previa. We can also grade it as grade 1, grade 2, and grade 3, grade 4. So the types of placenta previa, we have low-lying placenta previa. So in low-lying placenta previa, this is where the placenta is attached to the upper uterine segment, but it's dips into the lower segments. So in here, the bleeding is mild. Then the maternal and fetus condition, it can be good. Then the second one is marginal, which is also grade 3, placenta previa. So in here, the edges of the placenta reaches the margin of the internal os, but it does not cover it. Then the bleeding here, it can be moderate. Then the condition of the mother and the fetus varies, but the fetal hypoxia is likely to be present. Then on stage 3, which is partial or incomplete placenta previa, in here, the placenta covers the internal os. Then the grade 4, which is also known as complete placenta previa, here, the whole placenta covers the internal os, which it is centered, covers the internal os. Then in this is a major placenta previa. Thank you very much for your attention. This is the end of my presentation. I'll hand over to my colleague.
Good afternoon, everyone. My name is Mbena, and I'm going to continue from where my colleague has ended, and I'm doing the management. This patient was in the wards, so we did the management and also noted the problems that the patient would be facing or would have been facing, and prevented some of the complications that the patient which would have arisen from these problems. So we formulated a nursing care plan, which I'm going to run you through, and also tell you about the nursing interventions that were done on this patient. So the first problem that we came about was the risk of deficient fluid volume. So risk of deficient fluid volume related to active blood loss secondary to disrupted placental implantation. And our goal or objective was to help the patient maintain fluid volume at a functional level throughout hospitalization. And several international interventions were done. And this is what we did on the patient. We ensured that the patient has had lactobal cannulas, which were inserted and they were patent for fluid replacement and also for blood transfusion if necessary. We assessed the odor, the color, consistency, and the amount of vaginal bleeding by weighing parts to provide information about the active bleeding versus the whole blood, tissue loss, and degree of blood loss, and also to do a 2-weekly full blood count test to monitor the hemoglobin levels. Mind you, this woman has been bleeding, so the woman had mild anemia at this point. We monitored in the hourly intake and output of fluids, which provided information about maternal and fetal physiologic compensation of blood loss. And after our nursing interventions, this is what we evaluated. The patient maintains fluid volume possibly evidenced by adequate urinary output and also stable vitals. The second problem we came about was the risk of torrential bleeding. Risk of torrential bleeding due to low lining of the placenta. Our goal was to minimize the risk of patient bleeding and also to be alert for any signs of bleeding throughout hospitalization. And then our interventions were, we did group and cross-matching for possible blood transfusion. We administered blood transfusion as indicated to prevent hypovolemic shock. We encouraged the patient to avoid strenuous activities which would have aggravated the bleeding. We prepared the patient on what to expect in pre-op and also post-operatively. And our evaluation at this point, the patient did not bleed throughout our interventions. The third problem was impaired physical mobility. This patient was thought to be on total bed rest because we didn't want her to do exercises or do activities that will dispose her into bleeding. So the patient was confined to the bed. Impaired physical mobility related to active restriction and increased risk for bleeding. Our goal was to prevent complications that comes as a result of reduced mobility, such as hypostatic pneumonia and also deep vein thrombosis. Our interventions, we educated the patient on the importance of reduced activities to promote compliance and also cooperation. We encourage the patient to take part in minimal activities such as walking to the bathroom, standing up, and also walking around the bed for not more than 20 minutes. We did passive exercises to prevent deep vein thrombosis. We encourage the patient to lay down on the sides to maximize the flow of blood. And our evaluation, the patient was free from these complications, which are hypostatic pneumonia and deep vein thrombosis, evidenced by the absence of the patient not having any signs of dyspnea. The fourth and the last problem we came about was anxiety. Anxiety related to threat of death to self and also the fetus. And our goal was to allay anxiety throughout hospitalization from this patient. We educated, under our nursing intervention, we educated the patient and explained the condition process in order to allay anxiety. We also involved the patient in our daily routines and also activities that we are doing to gain cooperation and also act as diversion therapy. We gave the patient psychological care to allay anxiety. And our evaluation afterwards was, anxiety was allayed, evidenced by patient verbalizing of acceptance concerning the condition, and also the patient by responding to questions which were asked. This patient was being nursed in a ward, and the doctors saw the patient and also they formulated a delivery plan, which was followed to the latter. The delivery plan is as follows. The aim of this delivery plan was to deliver the patient and deliver the unborn child at 38 weeks of gestation. The first point was to keep IV access at all times. The second point was to do group and cross-match and also keep the results in the ward for any emergencies. The third point was to do a 2-weekly full blood count with the aim for greater HB of above 10 deciliter. The fourth point was 2 weekly ultrasounds. In this case, the patient had placenta previa, and the placenta was unlikely to migrate. The fifth point was to monitor vital signs and also vaginal bleeding by doing pad count and also inspection. The sixth point was to monitor the fetal well-being by formulating a click chart and doing it 6 hourly, and also monitoring the fetal heart rate by doing auscultation. The seventh point was the usual antenatal care, which was being done in PO3, where the patient was being nursed. Number 8, if preterm labor onset or profuse vaginal bleeding with potential cause of hemodynamic instability, we prepare the patient and hand over to the team on call for immediate cesarean section. The patient was in the wards up until the 10th, where the patient felt some sudden bleeding. And this is why we were asked to ask to formulate a delivery outcome. So on the 10th of March, at around 10 hours, the patient reported a sudden increase in the blood loss, and the doctor on call was informed. On examination, profuse vaginal bleeding was observed. The fetal heart rate was on the lower side, with which was 100 beats per minute. Maternal vital signs were also on the lower side, which was 90/59 millimeters of mercury. The pulse had increased to 115 beats per minute. The doctor requested to prepare the patient for an emergency cesarean section. Urgent cross-matching of blood and full blood counts were ordered and were done. Cesarean section was done, and the baby was born with an APGAR score of 5/15, or 5/10, with a moderate asphyxia. Baby was transferred to NICU for further management, and the mother was taken to OICU for also further management. At this point, these were the possible complications that would have arisen if certain interventions were not carried out. So on the maternal side, the possible complications were hemorrhage, which is the patient bleeding excessively, and also which can lead to the patient going into hypovolemic shock, which is the second point, and also which can lead to and the third point, which is disseminated intravascular coagulation due to reduced fibrinogen or platelet levels in the blood. And the fourth one, the patient was predisposed to become anemic. And on the fetal complications, prematurity was the major complication, because the baby was going to be born. At this point, the baby was born prematurely. The second point was respiratory distress syndrome, which is RDS, and also asphyxia, which the baby was born with. At this point, I'm done with my presentation, and I will invite our moderator, Mr.M.Kabangasheshe, to take over. Thank you.
Thank you very much. That was a wonderful presentation for the team. So we have just said the team presentation of the case study on placenta previa that was done from the University Teaching Hospital by our students. So our students went through the demographics, the history, the physical examinations, together with the investigations that were done. And later on, they also explained the kind of management that was rendered this patient. In addition, the students have been careful also to explain to us some of the possible complications that we have indicated against. So at this stage, I think I would like to take the floor back to the host and see if we have questions in our segment. Host, the floor is yours.
Thank you, Kabangasheshe. Presenters, job well done. Excellent presentation. Very detailed, very clear, very straightforward. Job well done.
Thank you.
So before I open the floor for question and answer, I would like to do a roll call to find out who is in attendance. You can respond by raising your hand. I'd like to find out, do we have any students listening in from UTH? You can just raise your hand. Do we have any students tuned in from UTH? Cassie? Grace? All right, thank you. You can lower your hands. What about from Levy? Do we have any tuning in from Levy? Again, you can answer by raising your hands. My apologies, I can't pronounce this name. Ah, Dr. Said. Now I see it. Thank you. Dr. Said. We have Wise, Ampande. All right. Do we have any listening from any of our main campuses? Alice? Mildred? All right. We have Gift. Excellent. Thank you. You can write where you're listening from, also in the comments, just in case I might miss any areas. Do we have any students listening from Kitwe site? Kabwe? Chipata? All right. Please note that the comment section, or rather the chat, is still open for you to comment your location. That's fine. So the floor is open for question and answer session. As usual, a reminder, we have iPhone from Levy Hospital. Excellent. Thank you. Thank you. So Grand Round, once again, is a platform for you, our students, to learn how to present as well as to interact online, so that you get used to interaction, you get used to asking questions, you get comfortable with writing your questions, raising your hand to ask questions, as well as engaging with not only the presenters, but also the professorial team. So please, simple house rules, always keep your mic muted until it is your turn to speak. That's if you have raised your hand and the floor has been given to you. So we have a few more. We have Edifi from Sapagrama Pharmacy in Chinsali. Welcome. Welcome. We have Luendo from main campus, our Chalala campus along Kasama Road. We have Menda from Mufumwe District Hospital. Welcome. Arthur from main campus, another one. Excellent. I'm noticing we have progressively more and more people listening in from Chinsali. So I would like to say thank you for those attending from that area. Please continue to share these grand rounds with all of your colleagues. We have Joseph from Minor Soko. Welcome. We have Patricia again from main campus. Now this is very good. This is very good. We also need more from main campus in itself. All right. So, question and answer session. This is a chance for you to ask your questions, share your comments, queries, or anything of the sort. You can do so by either writing it in the chat, or you can raise your hand. The floor will be given to you. There are no wrong questions. Don't forget that this is a learning platform. This is a chance for you to learn with your colleagues. So please, the floor is open. We have Kutemba from Sikanze Hospital. Welcome. So do we have any questions and or comments? No comments or questions yet? Please note that if you keep quiet for too long, I will start calling names, and we don't want that. To kick this off, I too have a question. Before I heard about placenta previa, I did not know this actually happened. So this is quite surprising to me. How common is this condition, let's just say within Lusaka? How prevalent is this condition?
So I'll pick this question. If I'm not really mistaken, you're asking how common this condition is in Lusaka, specifically. This condition is a rare condition in women, and normally it's due to certain effects that really cause this. But out of 100, they can rate it as a 2% of women who are having placenta previa. It's not really common.
Any other contributions to the team?
Just as my colleague has said, it's a condition, but it do happens, and it's important to take precautions in terms of visiting the antenatal, starting the antenatal early, to see if there are any abnormalities in where the placenta is situated. Yes.
Yes, like the way my colleague has said, this condition is not that much common. We can even rate it at 0.5%. It's not that much common.
I think those are your responses. Maybe a follow-up to that one also, like we may have students of different levels of training. Others may not even understand what placenta previa is. And you are mentioning segments of the uterus. And I think you can maybe clarify more on that one. How many segments do we have in the uterus? Is it 2? Is it 8? Some students may not know. Then in addition to that, as you're answering that, I'd like you to also maybe explain what can cause this condition. If at all there's no cause, what are the issues that can put women at high risk? So those are the two issues I want to clarify on. Segments of the uterus and predisposing factors. So you can share those. What you say.
So I can start with the risk factors. So the risk factors of placenta previa. One, it can be when fibroids, let me say it's fibroids, when the upper part of the uterine segment is filled up with the fibroids. So the placenta will locate itself in the lower uterine segment. Then the other one, it can be trauma. Maybe there was an accident which happened then. Yeah.
Pregnancy or any other type of accident. Okay.
Trauma, I can put it maybe if there was an infection, maybe they were doing vaginal examination, which can cause trauma in the cervix. Then the
Evans, you want to chip in?
Yeah, I want to, yeah. So just as she has said, trauma to the upper lining of the uterus can cause placenta previa in the sense that the walls of the uterus are going to heal by fibrosis. And then in this case, the placenta will not attach itself where there's been healing by fibrosis. So it will locate itself where there is no healing by fibrosis, in short. It will locate itself in the lower segment of the placenta. And also past cesarean section, which is also a result of healing by fibrosis in terms of that. So the placenta will also situate itself in the lower segment of the uterus.
Any other, or are we exhausted all the
So
possible predisposing factors?
also tumors, I think, it can cause tumor. It can cause also placenta previa. Yes.
Tumors, well,
In the uterus, yes. Yes.
uterine
Tumors.
tumors, okay.
And talking about the segments, so the uterus is divided into two segments. There is the upper segment and the lower segment. Under normal circumstances, the placenta is supposed to embed itself in the upper segment, which is known as in the fundus. So that's under normal circumstances. But if you find the placenta embedding itself in the lower segments, that means that the woman has, or the maternal woman has what? The placenta previa. Yes.
Thank you very much for those clarifications. And boss, do you have any questions?
First of all, presenters, excellent explanation. Also, thank you to you, moderator. We have a hand from Dr. Said. The floor is yours. Dr. Said, the floor is yours. You can unmute.
Okay. Okay, thank you very much, sir. Thank you very much. And first, I'm thanking all the lecturers who just have nice presentation. First, I have a question, but I have a comment. So, we hope if they have a chance for those lecturers, they have a presentation that.
Most can't get the questions because the transmission is broken.
Yes. Dr. Said, unfortunately, your signal is not very clear.
So, my question briefly always is tied into the.
Dr. Said, my apologies, but
Yes,
your
sir.
sound.
Do you hear me, please?
Your sound is breaking. I don't think your connection is strong. Could you repeat yourself?
Yeah. So, my internet is very, very bad.
Dr. Said, could you possibly write your comments in the chat, just so that we don't miss anything?
Okay. Yes. Okay, thank you very much. Thank you. Yeah.
Okay, thank you. We'll be waiting. All right. Question and answer session is still open. Do we have any questions or queries? So I would like to ask the audience a question. So far, those of our students in attendance, how well have you understood what placenta previa is? You can write your comments, or you can raise your hand. Or well, if we understood it. Grace, the floor is yours.
Okay, so I just wanted to make some additions, I think, on the predisposing factors of placenta previa. So what we should know, maybe just in terms, is that placenta previa is when the placenta is situated in the lower uterine segment. So normally the placenta implant in the upper uterine segment, but due to certain factors, you find that the placenta will locate in the lower uterine segment. And when we are talking about the incidences, so we are saying 2 to 5% of all pregnancies, they complicate into APH, and that is the antepartum hemorrhage. So the factors that are associated to this low-lying placenta are things like high parity. So high parity, we are talking about a woman that has had children more than 5, the grande Maltese. So like I said, that a normal placenta implants in the upper uterine segment. But in a case of high parity, you find that the room in the upper uterine segment would have already been used. So the placenta will not implant where the placenta, another placenta implanted. So they will usually look for a new place to implant. So in a case where the room in the upper uterine segment has been used or been utilized by the previous pregnancies, you find that the placenta will locate itself in the lower uterine segment. Then we have fibroids. So fibroids, these are benign tumors that are found in the uterus. So if there is any foreign body in the upper uterine segment, so the placenta will not implant where there is a foreign body. So it will go and find room where there is no foreign body, that is obviously in the lower uterine segment. Then we have things like twins or multiple pregnancies. So multiple pregnancies, we're talking about the predisposing factor will be because of maybe the placenta is big because it has to supply nutrients and oxygen to more than one fetus. So you find that a part of it will encroach into the lower uterine segment. So I just wanted to add on the predisposing factors. And the other thing would be the cesarean section because of the formation of the scar tissue in the upper uterine segment. Obviously, the placenta will not form where the scar had formed. So it will go and lie in the lower uterine segment. So those are some of the predisposing factors of placenta previa. So I just wanted to make an addition to what the presenters had already presented. Thank you.
Excellent. Thank you so much for that contribution. Presenters team, moderator, any feedback?
Mrs.Kasonde's contribution. The moment we are waiting for questions.
All right. We have Alice sharing her understanding of what this condition is. She wrote, placenta previa is a health condition which covers the woman's cervix, meaning it can lead to complications during childbirth as the cervix is blocked. That's what I've understood. Okay. Moderator?
Thank you for that. I think it's a wonderful contribution. So just adding more knowledge to what our team was trying to explain in terms of factors that may put a woman at a higher risk, and also trying to describe the condition itself, as in where is the issue arising from. Because we heard that this woman had experienced vaginal bleeding, and that is a serious concern, especially when the woman is pregnant. And our team was able to explain how they handled this case. So thank you for those contributions. Okay, boss, if there are any questions?
All right. So Alice, you have understood. Well done. Dr. Saeed's contribution. After clinicals and symptoms, how can we differentiate placenta previa from placenta abruption using ultrasound? Please give
read
details.
the question again.
After clinicals and their symptoms, how can we differentiate placenta previa from placenta abruption by ultrasound? Please give details.
You read the question? Yes. Would you like to start? All right. So, Evans, you can take it up, and colleagues will add on.
So, the differentials between placenta previa and abruptio, though you are specified to say using an ultrasound. I will talk about the differentials first between the signs and symptoms, the clinical manifestations between the two. Then I will briefly explain on the ultrasound on how you can differentiate. So in previa, the type of bleeding or the type of blood that comes out is bright red. As in abruptio, the type of blood that comes out is dark red. In the sense that abruptio, and also another point is in previa, the abdominal gauge is according to the gestation, and in abruptio, the abdominal gauge is increased compared to the gestation. Which means that in abruptio, this is where the placenta it will disattach itself from the lining of the lining muscles of the uterus. It's causing internal bleeding inside, and if it's concealed, you're going to find an increase in the abdominal gauge because the blood is within. And also in previa, the bleeding is painless. When the woman is bleeding, there will be painless vaginal bleeding. Contrary to placenta abruptio, in this case, the woman will be feeling a lot of pain, and also there will be abdominal gagging in this case.
Any other contribution? How would you differentiate between the two concerning placenta previa and the abruptio using ultrasound?
So using ultrasound, normally if you are trying to review the results of the ultrasound, there, like when you're trying to check, like my colleague said, for placenta previa, this is a condition in which the placenta attaches to the lower uterine of the uterus. Sorry, it attaches to the lower segment of the uterine. And then for abruptio, it's not necessarily to say it's going to attach to the lower uterine. It can be there on the right position, but it's okay. I feel like that's the difference. It will start separating. It can separate actually, but then in previa, it will still be there attached on the lower segment. If you checked on the diagrams that we gave you, that showed you, it will be the previa will always attach on the lower segment, either partially or complete. But then in the abruption, there it will be on the normal side, but then it will just be detaching from the uterine segment, the upper.
So I think another way you can differentiate between previa and abruptio using an ultrasound scan is that in the case of previa, it will show you where the placenta is situated. And also it will show you if in the case of abruptio, it will show you where the placenta is situated. But in the case of abruptio, there will be fluid, extra fluid, which means that the woman is bleeding, and that entails that the woman or the placenta is actually separated from the walls of the uterus. So in this case, in previa, it will just show you where the placenta is situated, and it will show you the grade of the placenta previa, the type of placenta previa that the woman is having. But in terms of the abruptio, it will show you, it can be in the upper segment, but it will show extra fluid around in the uterus, showing that the woman is bleeding. Yes.
Okay, but for the benefits of the students who are seeing the recording, maybe what's the difference between previa and abruptio? So that the audience know exactly what we are comparing against.
Okay, so for previa, placenta previa, in this condition, you find okay, what would be there, like we'll just do comparisons. In previa, you find there's a light blood, like it's not really dark, but it's bright. But in abruptio, it's dark. And then in previa, you find there's a painless bleeding, vaginal bleeding. But in abruptio, there's pain. So I think those could be kind of the differences, and maybe my colleague can add on to that.
Yes, I can add on. So the difference between abruptio and previa. In previa, you can find that the uterus is soft. Then in abruptio, it's tenderness. There's tenderness. Then in previa also, you can find that it's commonly allocated in the lower uterine segment. But in abruptio, it's always, you can find it on the normal side, like on the upper uterine segment. But the only problem there's what? There's detachments.
You mentioned soft and something. I wanted to clarify that. What do you mean soft? And what are you doing to say this is soft and this is hard?
So in previa, when you are palpating the uterus is felt, it's very soft. But in abruptio, when you are palpating the uterus, mostly it's tender. There's tenderness.
So the patient will be in pain?
Yeah, the patient will be in pain. But in previa, it's painless.
Yes. I think the simpler way we can differentiate between the two, previa and abruptio, previa is just the implantation of the placenta in the lower segment, and then which would cause maybe say blockage or complications during childbirth, because the placenta mainly will be covering the internal cervical os. And then in abruptio, it's just the placenta can be attached in the upper segment, but it detaches as the pregnancy develops. So in abruptio, it's just a detachment of the placenta before the delivery. Yeah. And then talked about the tenderness, and yeah. So in abruptio, we have what we call concealed, revealed, and also mixed type of bleeding or abruptio. So when it's concealed, it means that the bleeding is confined inside the uterus, inside the lining of the layers of the uterus. And then if it is revealed, it means that the woman is bleeding and the blood is actually coming out like that. So if it's concealed, and the last one is the mixed one, where there is both concealed and mixed. So in this case, if a woman has maybe say concealed or mixed, the abdominal gauge, it will increase, surpassing the gestational age. And then when you try to palpate the abdomen, it's going to be a bit hard because of the blood which has seeped into the walls of the uterus, causing it to become a cover layer uterus. Yes.
Well, thank you for those clarifications. And back to you, host. I was just trying to quiz my students concerning some of the questions that we are raised. And maybe Madam Kasonde, if you can help us on the question that Dr. Said raised in terms of differentiating placenta previa and abruption just by using ultrasound scan. Maybe you can clarify more on that.
Team, well done. Dr. Said says, thank you for your great answers, doctors. I've understood. Well done. Well done, everyone. We have another comment from Cassie. She says, just an addition on the difference. Placenta previa, the placenta is near or covers the cervical opening. Placenta abruption, the placenta detaches prematurely from the uterus. Today's grand round is very thorough. This is excellent. Do we have any other questions or comments? Please don't hesitate. This is an open platform. Any questions, comments, and/or observations? Please don't hesitate. This is your floor. This is your time. I still like to ask a question. If in the worst case scenario, please correct me if you've already stated this earlier. If in the worst case scenario, what is the last resort taken to save both mother and child?
So the question is, what is the last result in this case? That will give us the best outcome for both the mother and the unborn baby. Okay. If waste comes waste, what is it?
In case of any complications, for us to save both the mother and the baby, if you checked on the last part of the presentation, we came up with something which is the delivery plan. So there on the delivery plan, that's scheduled for an emergency. In case of any emergency, the woman will be taken for cesarean section, where they will have to open up her and also deliver the baby in order for them to save both the mother and the baby, because there is severe bleeding, obviously, and also other sorts of complications there. So the last resort there is a cesarean section.
Any additions? No.
So just as my colleague has said, in the worst case scenario, cesarean section is the best or the only option we can do to save both mother and the baby. And if there is excessive bleeding after the delivery of the baby using cesarean section, the last resort is to do an hysterectomy, where we remove the uterus to prevent the woman from bleeding out. Yes.
Okay. Thank you for those contributions. Mahongo, do you have any inquiries more than that? I think that's all also. Okay. Host, do you have any more questions?
Great, thank you, thank you. We have one from Edifi. Ultrasound is not so sensitive with differentiating the two, especially on the part of placenta abruption. And therefore, differentiating the two should mainly be based on clinical presentation as stated by the students. Thank you for that. All right. In the interest of time, if we don't have any other questions or comments, I would like to invite our professorial team. In the house, we have Professor Lambert, Professor Mwaba. Who else do we have? We currently have our two members from the professorial team present with us. Professors, are either of you able to take the floor?
Yes, yes. Can I start?
Welcome, Professor Lambert. The floor is yours.
Thank you very much. I think for the team, this is a job well done. Very good.
Thank you, sir.
Excellent presentation. And as usual, the moderator, you are so powerful. So is Mrs.G.Kasonde. Please, you heard your talk. Now, I have a few comments to make. History taking. You should be saying what are the presenting symptoms. Extremely important. In this case, it was the blood loss, hemorrhage. And how do you differentiate? What's the color of the blood? You should be stating that. The color of the blood will help you. Is it upper segment bleeding? Because if so, by the time it's coming out, it will look darkish. So the color is very important. Is it fresh blood, no pain related that it came out? You suspect that it's lower segment bleeding, most likely placenta previa. And please also assess the time we are seeing the patient for first time. In this history, I was so impressed because we've been saying in the history what time the bleeding started and when are you receiving the patient. Please keep that duration because some patients are referred late. And imagine if there's continuous bleeding. If there are late admissions, you will see that even when you are doing admission vital signs, those are extremely important. Vital signs. Because if there's a blood volume loss, you know it's going towards the hypovolemic shock. And there are signs, the pulse rate. If you read shock notes, please read shock notes. You are interacting with our medical student. Read the topic on shock. You will see that the first symptom is the pulse rate changes. In this particular case, you recorded very well. What was the pulse rate you were seeing? It was 106 beats per minute. Blood pressure was 100 over diastole of 53. That's what I had. But both blood pressure and the pulse rate, they are pointing that the cardiovascular system is not performing well. There's something going on. Now, related to respiratory system, what were the breath per minute? It was 20. For an adult person, what is the normal? You should always ask. Normal should be 16 breaths per minute. But in this case, you are receiving at 20 breaths per minute. That is high. So both respiration, pulse rate, they are high. Blood pressure, because maybe you didn't know what was normal, because antenatal card will show you. Always get the antenatal card. It will show you. Is this blood pressure what it is? It's reduced. It's reduced. And you noted there was a pallor. I was very happy when you said that. So on the examination, marry with what you have taken on the history. You want to estimate what is the amount of blood lost at the time patient is coming to you. Then you did urinalysis. Okay, that's again very good. You did well, because sometimes you may be carried away to vaginal bleeding, maybe in the urine as well. She has been losing. And in the antenatal card, check, did they even do stool examination? Because especially where you are, no, we are getting audience now from Mufumbwe, Chinsari. I'm so pleased with that. So this information will be going when you qualify, when you go, have this open mind of checking everything. What else can make the mother lose blood? So that's why we say stool examination is also important. The color of stool. If it's the upper GIT bleeding, to be malignant stool. Have you seen the color again? Is important. If it's a hemorrhoid lower down, it will be fresh blood. So these things can occur in the same patient. So look out for all these that can contribute. Now, HB, I'm so happy you did HB. It was 8 grams. What do you think? What should it be? Would you know the normal HB for Zambian women and Zambian men? Do you know? What should it be? For women in Zambia, it's 12 to 14 grams, which would be normal range. 12 to 14. If I to be exact, in the late 70s, it was a study that was done at the School of Medicine. It was a 12.6 for women and 14.6 for men in Zambia at that time. Maybe nutritional changes have occurred now, but you can't accept 8 grams as a mild thing. It's quite, remember, this is a pregnant lady. She needs enough blood, her own self and the fetal blood supply. So please, this was the law. You should have been consent. And then you called it mild anemia. I don't know why you called it mild anemia. If I give you these normal ranges, take it seriously. So start treating. And don't doubt about grouping and cross-matching from the word go. Don't wait. In this particular case, it was deteriorating because at the time the doctor was deciding to do cesarean section, blood pressure had dropped to 90 systolic over 59. So both systolic and diastolic have reduced. Now look at the pulse rate. What was it? 115. It has increased. And the fetal heart, in this particular case, it was 106. Earlier on, it was it was 120 fetal heart. Now it is reducing to 100. And you very well stated that this fetal life was also in danger. So you are monitoring both the mother and the fetal life. I was very impressed with that. That's how we should be looking holistically, the patient, the mother, and also the unborn baby. Look at them very well. Cesarean section. Should it be an emergency cesarean section? It's a patient who is in your hands. It should be elective. You should plan the cesarean section. Now we are gaining time by saying, no, we can't do it at 36 weeks. We wait until 38. I think that's the point you brought up. Why do we do that? It's to allow the lungs of the fetus to strengthen, because surfactant production in the fetus, you are talking of fetal life, surfactant production by alveolar epithelial cell type 2, the surfactant producing cell will keep the alveoli open when you deliver this child. So you are giving it time to mature. so that the surfactant production is adequate. I wanted you to have that in mind. Why you don't want to do it at 34 or 36, you want to delay up to 38. You are giving a chance for the fetal maturity to take place. Otherwise, it's very, very well done. Cesarean section, as I was saying, have it planned. Now, suppose you are in a rural health setting, a rural health center, and you get a patient like this. What will you do? Apex, what are you going to do? First of all, wherever you're going to work, and you get a case like this, is to know the geographical location of your health service. Which is the nearest health facility that is able to do cesarean section? Where is the obstetrician and gynecologist? How far is it from where you're operating from? Can you send the placenta previa bleeding heavily? Will the patient reach there? If so, send electively, say, I've limited the patient, fresh blood bleeding, don't do vaginal examination, please. Don't ever try. I told you the story of one professor in the obs and gynae within UTH. He had to go with a hand inside up to theater. Because he said, PV bleeding, you don't do vaginal examination. But people like me, because of experience, I can do a gentle one. And everybody is watching. He puts his hand in. It was a gush of blood. The whole hand. And he says, but please, let's go to theater. He went to theater up to the operating table. A mistake. PV bleeding, don't do vaginal exam. Imagine if it happened with you at a rural health center and cesarean section can only be done 40 kilometers away. What will you do? Don't tempt yourself. I'm happy none of you talked of possibility of assessing. Then the question of ultrasound. How I wished our expert, because we have Faculty of Radiological Sciences, and we have experts there who can do ultrasound. By the way, Apex has the latest equipment on ultrasound. I'm just trying to say, I wish one of them could have attended this to comment on the role of ultrasound. And do we have ultrasound wherever you're going to work? Please, if you are working in a rural setting, try to know where is this equipment nearest, so that you repair and plan together with them, so that you make a proper diagnosis. Otherwise, Ms.G.Kasonde, I'm so pleased the way she described some factors which were left out on how we can see why certain placenta previa, the career section, multiple pregnancies, see how it came out, the fibroids, the loop, foreign bodies and all that. But otherwise, I'm so pleased. Please acquire this knowledge. You are meant to be the best practitioners with open mind. Go and look after our people well. Go and look after, save many lives, both fetal and maternal lives. Thank you very much.
Thank you very much for this. I appreciate this.
Excellent. Thank you, Professor Lambert. Thank you so much. Presenters, I'm sure you've heard a lot of seasoned feedback from Professor Lambert. I would like to invite Professor Mwaba, our CEO. Professor, are you with us?
Yes, I think I would like to thank the team for a very wonderful presentation and thank Professor Lambert for elaborating on that. Now, what I would like to add is that medicine is not learned in compartments. Just because you are rotating in obstetric and gynecology should not just make you stay in the uterus. Your approach in a patient like this, as you are taking the history, should be what is the approach to a bleeding patient, male or female. In other words, I expect you to take this opportunity to go and read about hemophilias, the clotting cascades. What are the diseases that are inherited? What are those that are acquired? And then when you have ruled out those, you focus now the way you focused. It is very important that you go and revise the clotting cascade so that when you're rotating in medicine, you just plug in and cut. When you're rotating in surgery, you just cut in and plug those common causes of bleeding. So I will urge you to take this opportunity to go and revise bleeding disorders in general, and then confine yourself to obstetrics. Thank you very much for this wonderful presentation, and we thank you for the good hosting, Shinodo. Thank you.
Please and thank you, Professor. So, presenters and our students in attendance, you have heard it yourself. It's also reflected here in the comments. Dr. Sahid says, thank you, professors, for the great information. Another one, Edifi, thank you so much. Professor Lambert. We also have someone by the name of Critical Thinker. Much appreciated, professors. Well elaborated indeed. Another comment, really enjoying the presentation. It's quite elaborate. Excellent. Job well done. Job well done. We have, all right. I shall leave the comments there. But again, presenters, job well done. And as always, job well done, Kabangasheshe. Excellent moderation. Oh, your colleague, is that Dr. Kasonde?
Mrs.Kasonde.
Mrs. Kasonde. Also excellent. Thank you so much. We are now approaching the end of today's grand round. I would like to invite closing remarks from our presenters team. The floor is yours.
Thank you so much to everyone who tuned in. The viewers who are watching us, want to thank you for taking your time to actually view in. I want to appreciate the professorial team, Professor Lambart, Professor Mwaba, for being with us. It's been a really educative period for us, and the information that you've given us, it will surely go a long way in helping and saving lives in the near future. I want to thank the Dean of Nursing Faculty, Mrs. Masebe, and also the HOD of the Nursing Faculty, Mrs. Banda. I want to thank you, and also want to thank our clinical instructors who have been doing a great job with us in the skills lab as we go to the wards. And also want to thank our moderators, Mr.M.Kabangasheshe and Madam Grace. Want to thank you so much for guiding us on what to do. It would have been so difficult if we were doing this thing all by ourselves. And I want to thank my team as well. They've been so good. They are hardworking and worked as a team. It would have been difficult if it was an individual team, individual work. So I want to say good up, thumbs up, guys, and let's continue like this. And also on the skills that we actually got from this venture we went in on this case of taking history comprehensively, and also learning on how to have a good rapport with patients, because it's very difficult to collect information from patients while the patient is not in cooperation with you. So it's all up to our lecturers who have taught us to actually have a good rapport with patients and also clients who are at the hospital. And yeah, overall, I want to thank the viewers and everyone, and thank you to the team as well.
Excellent job, presenters team. Well done. And I'm very sure that your particular presentation has set the bar even higher. This level of detail and attention, job well done. You've done it. I would like to invite closing remarks from our moderator, Kabangasheshe. The floor is yours.
Thank you very much. On behalf of Mrs.Kasonde, I'd like to appreciate the Vice Chancellor of the Institute, that is Professor Njelesani, and also special thanks to the professorial team led by Professor Lambart. We are always appreciating the contribution that we receive from the professorial team. Again, special vote of thanks goes to the head of our faculty, that is Mrs. Masere, and the three HODs, that is Mrs. Vanda, Kanya Mulenga, and Mr. Miller. Of course, not forgetting the faculty members who are always instrumental in guiding our students through these case studies, both lectures from the clinical areas and lectures from the classrooms. And special thanks to the team for this wonderful presentation. Like you have set the bar high. So congratulations to you.
Thank you.
Otherwise, job well done. Host, that is your floor now.
Thank you. Thank you. I would now like to invite closing remarks from our professorial team.
Before the VC comes in, I want to thank Dr. Saidi. I think I saw Dr. Saidi participating. No, thank you very much. And that's the spirit. Please, let's come together and help the younger people become the best practitioners as they go in the field. And also the faculty of nursing, the moderators, the faculty of nursing is very active on this grand round. We thank them. May I appeal to Mr. Mwila, the head of midwifery, please, he should really spread this kind of approach. You have seen Mkumbwe was with us, Chinsali was with us. That's the kind of coverage we want. 2 alumni. Please, when the alumni participate, we should know them. Which district are they participating from? We should encourage Madam Shinodo, Mr. Zulu, we need to publicize. Alumni are gaining a lot of good experience, and they can contribute from their practical experiences wherever they are looking after people from. Even in sub-region, we want to connect to neighboring countries because we have graduated so many who have gone to neighboring countries. I think yesterday there was a participant in physiotherapy who was participating from UK. That was very good. We want our connections to spread out. IT, we have invested in IT. Even when we go to the new site, our new Lusaka campus, we have invested a lot of money on how we can connect. Even international professors in Australia, Norway, Pakistan, UK, everywhere. Zambians in the diaspora. We want them to participate so that they can see what is happening at home. We can also benefit from what they are doing out there. So collectively, we shall make it better in every presentation. As for you, you are the stars of the day. I thank God for you. Thank you very much.
Thank you, Professor Lambert. Thank you so much. Do we have Professor Mwaba? Are you still in the house? No, I think he may have stepped out. So, presenters, job well done. We still have more comments with regards to your presentation. Y says, wonderful presentation. iPhone Wana says, amazing presentation, colleagues. We're so proud. Patricia Mumba says, wonderful presentation. Job well done. Continue to raise the standards, both as presenters and as moderators. So we have come to the end of today's virtual clinical educational grand round. This has been an excellent session. What a way to have a presentation on a Friday. And with that, we have come to the close. I would like to wish everyone a good rest of the day. Thank you.
Thank you. Thank you very much.